Today we're going to learn more about intraamniotic infection and endometritis. Intraamniotic infection, for short IAI, is when there is an infection that results in inflammation of any of the combination of these structures. So the amniotic fluid, placenta, fetus, fetal membranes, or the decidua. So this is why we are moving towards calling this inflammatory process intraamniotic infection versus chorioamnionitis, as the latter does not encompass the other structures. And this can affect 2 to 5% of term deliveries. So there's 3 main routes of infection. The first is ascending bacterial invasion from the lower genital tract into what's typically a sterile amniotic cavity. So there's actually local host factors that are present that help prevent the migration of bacteria from the lower genital tract into the amniotic cavity. The first is something like the cervical mucus plug and also the fetal membranes. And this provides a physical barrier. And then the membranes themselves are actually found to have antimicrobial activity and found to have cells that activate the innate immune response to recognize virulent parts of bacteria and viruses. And lastly, within the vagina, there's peroxide-producing lactobacilli that can induce changes in vaginal flora that impair the virulence of pathogenic organisms. So the common bacteria to think about in this route include uroplasma, any gram-negative anaerobes, mycoplasma, group B strep, and E. coli. Another route is through invasive procedures, such as amniocentesis or chorionic villus sampling, and the bacteria to think about here is Staph aureus. And then the third route is through a maternal systemic infection that then infects the intervillous space, so something like listeria. There are multiple risk factors that can increase the risk of IAI, and these include cervical insufficiency, low parity, multiple digital exams, use of internal uterine and fetal monitors, meconium-stained amniotic fluid, presence of certain genital tract pathogens that can then tract upwards, alcohol and tobacco use in previous history of chorioamnionitis or IAI. But it's important to note that these risk factors may not be independently associated with IAI, but they're more associated with the longer duration of labor and membrane rupture. There was a recent retrospective investigation of more than 2,000 people that were analyzed, or that they were analyzing cervical exams performed during labor, and they found that women who developed an intrapartum fever had more digital cervical exams than women who did not, but this relationship was not significant after adjusting for spontaneous labor, their Bishop scores, and rupture of membranes on admission. So there's multiple different factors that go into this. Complications of IAI can be broken into 2 groups, the fetal complications and maternal complications. The acute neonatal morbidity include things like neonatal pneumonia, meningitis, sepsis, and death. And long-term infant complications include bronchopulmonary dysplasia and cerebral palsy. This is thought to be due to the inflammation, the significant inflammation due to this infection. And there was a recent study it was a meta-analysis of 15 studies that found a significantly higher relative risk of cerebral palsy among primarily premature infants exposed to either histologic chorioamnionitis or clinical chorioamnionitis. But it's important to note that the overall absolute risk of cerebral palsy still remains quite low. So it's about 2 per 1,000 live births. In terms of the maternal complications, IAI can lead to dysfunctional labor. So things to think about is requiring increased intervention. So increased risk of cesarean deliveries, uterine atony that can lead to increased risk of postpartum hemorrhage, and need for blood transfusion. And this is thought to be due to the dysfunction, the resulting dysfunction of the myometrium and decreased ability to contract due to the inflammation. Other things to think about are endometritis, peritonitis, sepsis, so considering getting a lactate level, adult respiratory distress syndrome, and rarely death. panel of maternal and neonatal experts recommended separating IAI into 3 different categories. The first is isolated maternal fever, so a temperature, an oral temperature of 39 degrees Celsius or above times 1, or an oral temperature between 38 and 39 degrees Celsius 2 times, separated by 30 minutes apart. We'll get into the management of isolated maternal fever on the next slide, but it's important to always communicate a maternal fever with the NICU team, given that they could change their clinical management of the baby afterwards. The second group is suspected IAI, and this is when there is maternal fever plus 1 or more of the following. So it's a diagnosis based off of clinical criteria. The other factors are maternal leukocytosis, so a WBC count of over 15,000. And this would be in the absence of corticosteroids, ideally showing a left shift like a bandemia, but not necessary. Also fetal tachycardia or purulent or malodorous amniotic fluid. And it's important to also know that the National Institute of Child Health and Human Development criteria, they actually de-emphasize the use of maternal tachycardia in this suspected IAI category, and also de-emphasize the use of fundal tenderness. The third category is confirmed IAI, and this is based on a positive amniotic fluid test result, so using a gram stain, low glucose level, or a culture, and with results that are consistent with infection, or placental pathology that demonstrates histologic evidence of a placental infection or inflammation. So in clinical practice and on the labor and delivery floor, confirmed IAI infection among women in labor at term will most commonly be made after delivery based off of the histo study of the placenta. So we will mainly be needing to manage, in the moment, isolated maternal fever and or suspected IAI. So when thinking about an isolated maternal fever, it's also important to think about the many etiologies that can cause a maternal fever intrapartum. So misoprostol use, having an epidural, it's been linked to increases in IL-6, which can cause fevers. And then also thinking about other sources, so urinary tract infection, respiratory infection. And ACOG notes that markedly elevated maternal temperatures are most likely due to infection versus transient lower temperatures that don't meet the criteria of the fevers defined as on the slide previous to this one, could be due to infection, or they could be related to non-infectious factors such as dehydration or epidural. So there's limited data that guides appropriate management for an isolated intrapartum fever in the absence of other clinical signs. However, intrapartum fever alone, whether due to infection or not, has been associated with poor short-term and long-term neonatal outcomes. The mechanism of this is still unclear, but it's thought to be due to fetal hyperthermia and associated changes in metabolic rate, and this can potentiate the negative effects of tissue hypoxia. So the use of intrapartum antibiotic treatment given either in response to maternal group B strep or in response to evolving signs of IAI during labor has been associated with a nearly 10-fold decrease in GBS neonatal sepsis. So given the potential benefits for the patient and the newborn, antibiotics should be considered in the setting of isolated maternal fever unless a source other than IAI is identified and documented. So whether or not a decision is made to initiate antibiotic therapy, it's really important to always communicate this maternal fever to the NICU team, as this can change their management and clinical assessments of the baby after delivery. There are many benefits of treatment for suspected or confirmed IAI. The benefits include decreased rate of neonatal bacteremia, pneumonia, sepsis, maternal febrile morbidity, and length of hospital stay. So it's important to treat the suspected or confirmed cases. Also, for the suspected confirmed cases of IAI and also for the isolated maternal fever, antipyretics should be administered given the risks of fever that we talked about on the previous slide. We should also be looking at proper labor progression, given the association between IAI and dysfunctional labor progression, and the potential increased risk for further interventions. And IAI is rarely, if ever, an indication for cesarean delivery. And again, it's really important to communicate these findings with the NICU team. On this slide lists the antibiotic regimens that are recommended. So first line would be ampicillin and gentamicin. For a mild penicillin allergy, you could give cefazolin and gentamicin. And then with severe penicillin allergy, the patient could get clindamycin or vancomycin and gent. Alternative regimens are listed below. Post-delivery or postpartum, intrapartum antibiotics should not be continued automatically, but rather we should be thinking about risk factors for postpartum endometritis. So the presence of risk factors include maternal bacteremia, persistent fever. This can be used to guide our continuation of the antimicrobial therapy, the duration, and also thinking about the route of delivery. So in post-cesarean delivery, 1 additional dose of the chosen regimen is recommended, and also adding clindamycin or metronidazole. Post-vaginal delivery, the risk of endometritis is lower, and therefore the patient may not require postpartum antibiotics. So no additional doses are required or recommended unless there are other signs or symptoms that we talked about earlier. But if given, clindamycin is not indicated. So next we'll just talk about postpartum endometritis briefly. Postpartum endometritis occurs when infection is not totally cleared out after delivery and affects the endometrium. So risk factors include IAI infection, cesarean delivery, prolonged labor or rupture of membranes, manual placental removal, and then all of the IAI risk factors discussed previously. The diagnosis includes a postpartum fever, plus maternal tachycardia, uterine tenderness, which is midline fundal tenderness, foul-smelling lochia, and or a maternal leukocytosis. The treatment for this includes clindamycin and gentamicin. If GBS positive, I would add ampicillin, and this is what's called triple therapy. And the patient should be treated until 24 to 48 hours afebrile. Additional oral antibiotic therapy after successful IV therapy is not required, as there have been many randomized controlled trials that have demonstrated no improved outcomes for continuing oral antibiotic therapy after IV. Here are the references that I used to create this PowerPoint. I hope it was helpful and that you got a further understanding about IAI and postpartum endometritis.